Hi, I'm Betsy tanenbaum, and I'm a nursing student at the University of Michigan. Today, I will be presenting a patient to you. Patient is a 21-year-old Caucasian female who is a full-time student and is currently living in Michigan. Patient was admitted to the University Hospital on December 4, 2015 for uncontrollable and persistent painful bowel movements. The patient's vital signs upon admittance were temperature of 37 degrees Celsius, respiratory rate 16 breaths per minute, pulse 82 beats per minute, and blood pressure 115/70. During Thanksgiving break, patient had had right lower and left lower quadrant abdominal pains and lower back pain accompanied by persistent bowel movements, so she visited a gastroenterologist in her home state of Florida. Initially, the patient perceived her pain to be due to food poisoning. However, the doctor concluded that she had C. diff, which stands for Clostridium difficile infection. As a result, patient was put on an antibiotic that initially helped her pain. However, once she finished the dosage, her pain returned. Patient had gone home in between Thanksgiving and her most recent hospital visit to revisit her abdominal pains. At this time, it was thought that she was lactose intolerant and/or had celiac disease. Patient then stopped eating dairy and gluten products. Once again, her painful symptoms diminished for a short time but then returned. About 1 week prior to this hospital visit, the patient's painful bowel movements became more frequent and more disruptive to her daily life. Initially, while conducting daily activities, there was no pain. Patient was still able to exercise at this point. Pain was only generated right before a bowel movement and would persist until the stool was deposited. Pain would then go away until the next bowel movement, about 50 minutes later. Patient said she went to the bathroom at least 6 times during the day and 3 times during the night. At this time, the stool was described as dark and loose. Aggravating factors included drinking coffee, while relieving factors included drinking alcohol. The patient also noticed that her menstrual cycle was absent during the past 2 months, despite being on birth control and usually getting her period regularly. The patient complained of itchiness and irritation of the skin on her inner buttocks region, which was further aggravated by the passing of each stool. A few days later, the pain got worse. The number of bowel movements increased, and the color changed. The patient was no longer able to exercise, attend class, or leave her room in fear of having an accident. Patient's appetite had also dramatically increased, while her energy level depleted because she was unable to retain any food that she ate. Patient's bowel movements were precipitated by a jolting pain that lasted longer after the stool was deposited and were now occurring every 10 to 15 minutes. Patient described her stool as bloody and loose. The night the patient was admitted to the hospital, she reports throwing up blood. Upon patient's release from the hospital, it was concluded that patient had ulcerative colitis, which is a recurrent inflammatory process causing ulcer formation in the lower portions of the large intestine and rectum. She was prescribed prednisone 15 milligrams for 10 weeks. Patient denied having any childhood illnesses. Patient was up to date with all vaccinations needed for college, including meningitis, tetanus, polio, hepatitis, and varicella. Patient also reports getting an annual flu shot. Patient has no allergies or known drug reactions. Patient was also hospitalized for 2 days in kindergarten after getting her tonsils and adenoids removed. Patient was also hospitalized for 2 weeks in February 2013 due to a post-op bacterial infection that spread to her whole body after having all 4 wisdom teeth removed. Patient has been taking Prozac 15 milligrams daily since she was 14 years old. Patient was also on low estrogen birth control and Lialda 1.2 milligrams, 4 tablets daily to help regulate her stomach. The patient has a healthy diet during the day but reports binge eating at night. Her fiber intake is normal, however she sometimes takes Citracel, a fiber supplement to help regulate her stomach. Patient exercises 3 to 4 times a week and sleeps 6 to 10 hours each night. The patient drinks 1 cup of coffee a day. The patient also reports recreational drug use and alcohol use, drinking at least 3 times a week, and smoking marijuana 2 times a week. As a full-time third-year college student, patient is currently living in an apartment with 1 roommate. She is currently single and reports being moderately stressed from schoolwork. Patient does not believe there are any environmental hazards and does not participate in any cultural or spiritual practices. Patient sees her family pediatrician once a year and her gynecologist twice a year. Patient reports no one in her immediate family having abdominal problems, cancer, other diseases, and/or surgeries in the past. Based on these findings, I decided to perform an integumentary and abdominal assessment. Before I conducted these physical examinations, I gathered some subjective data. The following data was conducted about the integumentary system. Patient describes skin as fairly clean with no scarring, acne, or rashes. Patient hadn't noticed any changes in the color of her skin, although she felt a little flushed from constantly going to the bathroom. Patient normally doesn't sweat a lot and reported no night sweats or diaphoretic episodes. Patient reported having drier skin than usual because she was used to the warm weather in Florida. Patient denies history of allergies, rashes, or other skin problems in her family. Patient frequently bathes in the sun but always uses protection. Patient reports itching on her buttocks and inner buttocks region for the past week. Patient claims that itching got more irritated when she went to the bathroom. She rated the pain a 5 out of 10. She doesn't report ever seeing blood. To treat the dryness and soreness, patient applied cortisone cream to the area after each bowel movement, which temporarily soothed the pain. Patient hadn't noticed any other tender spots or painful areas on the body. Next, I collected subjective data about the gastrointestinal system. Patient describes having a significant change in her diet over the past 2 months. Because her stomach was constantly upset, she eliminated all dairy and gluten from her diet. Patient's appetite also increased because nothing she ate was digested. Patient reports no subsequent weight loss, but a depleted source of energy and increased fatigue. Over the past 2 months, patient's bowel habits have changed. Patient reports going to the bathroom a minimum of 6 times per day and a maximum of 20 times per day. The stool progressed from dark and loose to bloody and loose about 1 week before her most recent hospital visit. The patient denied use of laxatives or antidiarrheals during this time. A jolting pain was associated with each bowel movement until the stool passed. Bowel movements began occurring every 50 minutes, but then increased to every 10 to 15 minutes. The patient had no increased passage of gas, but felt bloated. The patient had no history of ulcers, cholecystitis, cholelithiasis, cirrhosis, diverticulosis, or infection of the abdomen. The patient denies having nausea, heartburn, or constipation. The patient felt the most pain in her right lower quadrant and left lower quadrant. The pain was mostly felt before, during, and slightly after a bowel movement, although she did have discomfort in her lower abdomen and back. She rated the pain as an 8 when going to the bathroom, but when performing daily activities, she rated the pain as a 3 or a 4. Now I was ready to begin my physical examinations. First, I began with the integumentary exam. I began by inspecting the patient's scalp for flaking or lesions, which were absent. The patient had normal hair distribution on her head. Hair was dark, thick, and moist. The patient was diaphoretic, appeared uncomfortable, and was guarding her stomach. The patient rated her abdominal pain an 8 out of 10. I carefully inspected and palpated her abdomen for any lesions or scars, which were also absent. Her skin felt warm. The patient's extremities lacked any scars. The patient had no elasticity, edema of 0, and no tenting. I then inspected the nails for color, hygiene, shape, contour, thickness, and attachment, which were all intact. I also tested capillary refill on both her fingers and toes, which was under 2 seconds. I then had the patient turn over so I could inspect her back and anus. The patient's anus was red and inflamed. Patient complained of constantly itching her anus because it was dry from constantly going to the bathroom. There was no bleeding. However, the skin was cracked and dry. I then conducted an abdominal exam. The patient's general appearance looked flushed and a little green, and appeared to be in some discomfort. The color of her abdomen looked normal for race, and her umbilicus had no sign of discharge or inflammation. The contour was rounded, but there were no bulges or masses. There was no movement or surface motion. Patient's bowel sounds were loud, high-pitched, and rushing in all 4 quadrants, which was indicative of hyperactivity. No vascular sounds were heard. Patient guarded herself upon light and deep palpation in both the right lower quadrant and left lower quadrant. The aortic pulse was palpable, but was no wider than 3 centimeters. The Ehlers-Danlos test, obturator test, and Blumberg's sign were all negative, revealing no signs of appendicitis. 2 other pertinent systems that would be important to examine based on the history of this patient would be genitourinary and musculoskeletal. When the patient's symptoms were very severe, she stopped getting her menstrual cycle, even though she was regularly taking her birth control. For this reason, it would be important to assess the genitourinary system. According to the Crohn's and Colitis Foundation of America, when a woman's irritable bowel disease is active, the inflammation itself can cause the body to shut down normal hormone function. Many factors contribute to irregular menstrual periods, including hormone levels, adequate nutrition, and stress. During this time, the patient was also unable to perform her daily activities, including exercise. Lack of exercise could lead to stiffening of muscles and joints and cause weakening of muscles and contribute to an unhealthy lifestyle, which is why a musculoskeletal exam would be important to conduct. In a case study from 1993, it was found that ulcerative colitis can lead to polymyositis, which is a condition marked by inflammation and degeneration of skeletal muscle throughout the body. This concludes my focus assessment. Thank you for listening.